Our next abstract for presentation is S069, Validity Evidence for Novel Advanced Laparoscopic Suturing Tasks, again to be presented by Dr. Watanabe.
Good afternoon again. So here's my disclosure. So laparoscopic suturing is an essential technique required for a wide range of minimally invasive procedures. However, this skill is one of the challenging for surgical trainee to master. Evidence supports the use of low-fidelity benchtop models to develop the basic fundamental laparoscopic skills. However, and also transfer of these skills to real environment have been repeatedly demonstrated. However, a recent survey of the program fellowship council reported that 60% of the program directors felt that graduated general surgical residents are not proficient in laparoscopic suturing at the beginning of MIS fellowships. So there is a gap exists between the complex skills required to perform safe laparoscopic suturing in the OR and the basic skill acquired using current simulation models. So therefore, there is a need to develop the laparoscopic suturing tasks that better prepare the resident to participate in and learn from the cases requiring advanced suturing. So the purpose of this study was to develop the novel advanced suturing model and their matrix, and to collect the validity evidence for them as measures of laparoscopic suturing. So based on the need assessment conducted in our lab, so we identified 3 important skills essential to laparoscopic suturing that are not effectively taught and assessed currently. So we developed a low-cost 3 novel tasks using readily available materials. So needle handling, suturing under tension, and continuous suturing. So the aim of the needle handling task is to manipulate the needle at the desired direction and angles. And the suturing under tension skill task it requires a closure of a gap using 3 interrupted sutures. For continuous suturing, a hole located in simulated intestine is closed using a continuous suturing technique. So senior resident and surgeons from MIS and the bariatric surgery service were recruited to perform these tasks. In terms of matrix, a combination of the time and the error were used for calculating scores. And 2 later timed live performance and scored predefined error independently. So here's the results. 31 surgeons completed these tasks. 60% were surgical residents, senior residents, and 40% were MI surgeons. In terms of laparoscopic suturing experience without using haute suture devices, half of the residents have never performed the suturing in the OR, and the rest of the residents have performed less than 10 cases. And 60% of MIS surgeons performed less than 50 cases annually in their practice. So comparing the score between the resident and the MIS surgeons, y-axis is a task score, and red indicating the score of MIS surgeons. Compared to the senior residents group, the MIS group had a significantly greater scores on all tasks, especially on the under tension and the continuous suturing tasks. While all surgeons completed the 3 tasks within allocated time, out of the 18 surgical senior residents, some of them could not complete the task. Looking at the correlation score, correlation between the scores and the self-reported suturing experience. Again, red circle indicated MI surgeons. So the score of all tasks correlated positively with self-reported experience. As the annual case, suturing case increased, case of the task increased. So in terms of consistencies of the score between the raters, inter-rater reliability for all tasks were 0.99, which means a very little discrepancy between the raters to assess the time and the error component. Internal consistency was 0.80, indicating the scale measured using these scale are very similar but complementary to each other. In conclusion, performance all tasks correlated significantly with training level and self-reported suturing experience. And this study provided validity evidence for metrics of 3 low-cost novel advanced suturing tasks as measures of suturing task skills. And integrating these suturing tasks into the educational curriculum may help improve the residency suturing skills and better prepare the resident for operating rooms. Thank you.
Any question from the public?
It's a very nice presentation, a nice study. Was all of the suturing done forehand, and did you consider, one of the skills with advanced suturing with bowel surgery that is hard to teach the trainees is the backhanded suturing. Did you consider incorporating that in your model?
Thank you. That's a good question. So basically, we don't have any certain standardized process to complete the task. If they want to do the backhand suture, we allow to do it, but most of them didn't do that. But we are doing create the advanced suturing task curricula right now with certain university in the U.S. and North America. So we have a backhand suturing task, so that task could be integrated into the advanced suturing task curricula.
That's great, thanks.
And were the trainees provided any sort of moderated experience in these before being tested, or were they just immediately given the test? Was there someone who walked them through what the skills were, showed them what to do? Did they have any practice time, or was this just tossed into a room and told to suture?
There's no practice time for using this task, but we provided a standardized instruction video how to do it, so and how to assess what the error is, so that's we provided for collecting data.